Hey there, this is Rick Thomas with Thomas Family Insurance, come to you with this week's Medicare Monday. All right, at the end of the first quarter, I thought we'd take a look to see where things are at and where things are going. So we're going to take a look at the state of Medicare, similar to the State of the Union address that our presidents do. So, Medicare enrollment tends to indicate a continued preference for Medicare Advantage plans over Medigap policies. I'm going to show you some data on that in a little bit. We're going to take a look at some of the numbers and, more importantly, take a peek into something that's coming in for Illinois in 2026 that is huge. You don't want to miss this, especially for a certain demographic. Illinois is changing how they do some business in Medicare. So before we talk about where things are going, let's take a look at where things have been. So this chart shows the growth of Medicare Advantage plans since the inception back in 2007. I actually started working the Medicare business back in 2009, and things have really changed over the years. This trend is going to continue, and we can assume that Medicare Advantage plans are going to be the future for Medicare. This is my opinion. So when we look at enrollment and growth, over 50% of all Medicare beneficiaries are now enrolled in Medicare Advantage plans. That enrollment continues to grow every year. Currently, there are over 33 million people on Medicare Advantage plans. Younger seniors and new retirees are choosing Medicare Advantage plans over the original Medicare and Medigap plans at a quicker rate than normal. The extra benefits that we receive under Medicare Advantage plans change the dynamic. It's a math problem about value, not just about premiums. Where Medicare Advantage plans can offer dental and vision, hearing, transportation, fitness memberships, and some of them even have food and utility bill benefits. None of these are covered by original Medicare and the Medicare supplements. These perks are a huge draw, especially for people on fixed or limited incomes. There's also simplicity and convenience. It's one card, one plan, one monthly premium. A lot of times the premium's zero. And many of the plans are going to include the drug coverage with it, reducing the need to have multiple plans with multiple carriers. It's what is called a value based care. So, Medicare Advantage plans focus more on preventative care, care coordination, outcome based payment models, which align with the Medicare's broader goals. CMS supports these models as a way to control costs and to help to improve care. Now, Medicare Advantage plans may not be for everybody because the number one thing you need to understand about Medicare Advantage plans is they are networked plans, at least most of them. So sometimes we have to pay attention to the doctors that's in the network. Now, the plans that I will recommend to my clients have a robust network. We will talk about doctors and hospitals and places you can go, and I'll mention the places you can't go. But for the people who sign up over the phone or online, a lot of times they have no idea how limited the networks are. That is very, very important to understand with Medicare Advantage. Some Medicare Advantage plans will require referrals before you can go see specialists. The plans that I often will recommend do not require referrals. So that's again, having a good agent is going to help navigate your path accordingly. And people who travel a lot or they live in areas not with doctors are not inside the network, they might want to prefer Medicare and Medicare supplements because of that flexibility. They can go where they want as often as they want. They just pay that monthly premium and they don't have any surprises. And while Medicare Advantage plans often advertise zero premiums, they can come with some out of pocket cost if you need some extensive care. So sometimes you have to pay more over time than you would with a Medicare supplement policy. We're going to give you some examples of rates for Medicare supplements and compared to Medicare Advantage. And there's also plan complexity. So Medicare Advantage plans are going to change annually. Benefits, formularies, networks, all can change, and that can create some confusion. I call all of this stuff job security. As long as it's confusing, I will have a career, and I'm going to be there to help people navigate this madness. And unfortunately, with any insurance, including Medicare Advantage plans, sometimes we run into denials and prior authorizations. So, some recent reports show that some Medicare Advantage plans will delay or deny care more frequently than what original Medicare would. And this causes some concerns among doctors and hospitals and patient advocates. And they like Medicare better because Medicare does not look at prior authorization. So, this means two things: it's easier for the doctor and healthcare providers, and they can get away with more with original Medicare than they can with an insurance company. So while Medicare Advantage is the future, it seems to be headed that way. It's not universally loved. There are some people who love Advantage plans, and there are people who absolutely hate it. And I will say both parties need to be educated on the pros and cons to both. But Medicare Advantage is likely to remain the dominant model, especially as it continues to receive strong political and financial support from the federal government and private health insurance companies. It's designed to be more modern, managed, and value driven. However, original Medicare plus a Medigap policy still is important for the people who need it, especially for people who provide value provider freedom, travel, and they want to limit how much they have to pay into that monthly premium. All right. So, looking at where we have been back in 2024, anyway, over 50% of all Medicare beneficiaries, again, roughly 33 million people, were enrolled in a Medicare Advantage plan, also called Medicare Part C. As we predict what will happen in the next 10 years, the estimation is it's going to be over 70% of people on Medicare will be under Medicare Advantage plans. Now, we just think about that for a minute. In just one decade, traditional Medicare may become the minority choice. Why is that? That's because people are choosing convenience and cost savings and added value. So, why the shift? Medicare Advantage plans have done something traditional Medicare and Medigap plans never could. They became a one stop shop for healthcare. They combine Medicare Part A, Part B, Part D. They often throw in dental and vision, hearing, transportation, and some of them may have grocery and utility benefits. And for many Americans, especially those living on fixed incomes, these extras are not just helpful, they're necessary. Medicare Advantage plans also align with policy goals. It's not just about consumer choice. The federal government has heavily invested in Medicare Advantage as a model for value based care, cost control, and care coordination. Medicare Advantage plans reward health plans for keeping people healthy, not just for providing services. And that aligns with the long term goals for Medicare for sustainability. But it's not all perfect, and with this growth comes responsibility. By 2034, we're going to need stronger oversight. We're going to need to make sure that networks are adequate, make sure services aren't denied and you have to jump through a bunch of loopholes. And seniors need to understand what they're signing up for and what they might be giving up. Because the truth is, Medicare Advantage Plan is not right for everybody. It is something everybody needs to know about, but once you have the information, you can make the decision on what's right for you. Your neighbor's decision should not impact you, nor your decision should impact your neighbor. Everybody needs to learn this for themselves. So, what should we expect in the next 10 years? More people under Medicare, more plan options, more benefits, and hopefully, as long as I'm still breathing, there's going to be more education and support to make sure the choice that people make is going to be the right one for them. At Thomas Family Insurance, we're not just watching these changes, we're walking people through them, one conversation at a time. We believe that the right plan for the right person for the right reason is what really matters. So whether it's Medicare Advantage or Medicare Supplement, we're here to help the folks understand, compare their options, and choose with confidence. All right, so we're going to take a quick snapshot of how people across the country are choosing to get their Medicare coverage. There's a lot of numbers on here, but basically we are comparing special needs plans, employer union group plans, and individual Medicare Advantage plans. So we're going to see the numbers have changed from back 2010 down to 2024. The first column is special needs plans. These are becoming more and more common. Special needs plans we're going to talk about more later, but this could be a chronic special needs plan or it could be a dual special needs plan for people with Medicare and Medicaid. There's a special requirement that has to be met for people to be able to get a special needs plan. The green color here is employer or union sponsored group plans. These could be while people are still working and they're Medicare eligible, or a retiree program that the group or the place that they retired from is offering. Most of the time, these group or employer plans are Medicare Advantage plans. In some cases, they'll offer stipends to get Medicare supplements, but employer plans are more and more robust, dealing in the Medicare Advantage threshold. And the last number here is the percentage of people who have individual or Medicare Advantage plans. These would be the ones we buy on the street. So we combine these together, we're talking about 100% every time, but we can see the vast majority of these plans have been the individual plans. This would be like Aetna, Humana, WellCare, United Healthcare, things like that. So special needs plans are special requirements. Employer plans you have to be able to get from where you retired from or your spouse retired from. Then everybody else can get the individual plans. All right, special needs plans are growing, and this is a huge thing in 2026. So pay attention all the way to the end, especially if you live in Illinois and you know anybody who might also have Illinois Medicaid. The rules are changing in Illinois next year, and this is really, really important. All right, so we take a look at the special needs plans going back to 2010. We can see it has steadily grown up, and we're talking about millions here. So now we have over 6.64 million people last year on a special needs plan. So most of these are dual eligible. That's the blue. That's Medicare and Medicaid. The green is the chronic condition. That's for people who have diabetes or heart issues. This little bitty sliver, this purple, is institutional. This is for people who are living in the nursing homes. There have been some plans that were Medicare Advantage that were specifically designed for people who are living inside nursing homes. All right, so we're going to take a trip down in my time machine. So to help understand what the next 10 years are going to look like, we're going to go back 10 years. So this is a map of the United States. I mainly work in Illinois, Iowa, and Missouri. And if we go back 10 years to 2014, this shows you the percentage of people by state that had Medicare Advantage. So go back to Illinois, 10 years ago, 18% of the people on Medicare had Medicare Advantage. Iowa was 13%, and Missouri was 27%. Kind of give you an idea what was happening back in 2014. The iPhone 6 just came out. Let It Go was on every radio station all the time. And there are only 15.7 million people enrolled in Medicare Advantage. It's over twice that now. So that means 28% of Medicare beneficiaries were still under original Medicare, and most of the time they had a Medicare supplement policy too. Again, Missouri led back 10 years ago with the most of the Medicare Advantage percentage anyway. Then we go on to now, 2024, last year. We can see it has changed a lot. Illinois, we now have 42% of the people under Medicare Advantage. Iowa is 36%, and Missouri is well over 50%. At 56% of the people have Medicare Advantage plans. There are now over 33 million people in all, and over, again, more than 50%, like 53% of the people on Medicare have a Medicare Advantage plans. In those 10 years, Medicare Advantage plans became more attractive than ever. We saw more and more zero premium options. Dental, vision, and hearing, and grocery cards and utility assistance became more and more common. Coordinated care that's easier to manage under one plan. And what was once kind of a niche option is now the main way people are choosing to receive their Medicare benefits. So now we go forward 10 years, and let's take a look to see what we might expect. If the current trends continue, experts predict over 70% of everybody on Medicare will have a Medicare Advantage plans. That means traditional Medicare and Medicare supplements will become the minority. More care will be delivered through private plans working under a value-based model. And we'll need even more consumer education to help people navigate their choices. All right, for Medicare supplements, We're going to take a look at the numbers here. Remember, 33% of the people on Medicare have Medicare Advantage plans. That is 54%. In comparison, there are only 12.5 million Medigap policies out there. So Medicare supplement people, these are the ones that are on Facebook saying Medicare Advantage is the devil and it is horrible and you don't want the Advantage plan. This is a minority of people. Only 21% of people who have Medicare, that 12.5% of the 64 million people under Medicare, will have a Medicare supplement plan. All right, Medicare population and 42% of the rest of them are going to have traditional Medicare, maybe with Medicaid, maybe with employer coverage, but the Medicare supplements are a dying breed. They're becoming more and more rare, and because of that, the prices are going up. So the most common Medicare supplement is the G plan, followed by the F plan. So you can see the vast majority of the people will either be under the G or the F. Now the F plan has been sunsetted. That means starting in 2020, people who turn 65 cannot buy the F plan. So the people who have it can keep it. But as that pool of people get more and more older and sicker, we can expect the premiums to skyrocket under the F plan in comparison to the G. The third highest rate is the N plan, followed by the O. That's only in some waiver states. They're not available around here. Any of these other supplements, I can't really recommend. They're not going to cover the things that you think they're going to cover. Pretty much the G plan, maybe the N plan would be the supplements if we're looking at Medicare supplements. All right, we're going to take a look at the average monthly premium for a Medicare supplement, and we'll take a look at our area. So in Illinois, we are the most expensive of the average of the 3 states I work, coming in on average about $226 a month for a Medicare supplement. Missouri and Iowa are close to that, $222 for Iowa, $220 a month for a Missouri Medicare supplement plan. Again, these are the averages. The range could be much higher than that. We're going to take a real quick look at some examples. We're going to look at Illinois, Iowa, and Missouri because that's where the bulk of my business is. And I went to Medicare.gov to shop Medicare supplement plans. We can see the G plan for a 65-year-old female. The premiums, the cheapest option is $105, but it goes all the way to $467 a month for a Medicare supplement. That's at age 65. By the time she gets to 90, we're looking at premiums from $234 up to $568. Again, that is an Illinois G plan for a female non-tobacco user. If you use tobacco, we're almost doubling the premium in some cases. When we look at males, typically men are more expensive in the Medicare world. We tend to wear out quicker than women and have higher cost share the older we get. We can see a Medicare supplement for a 65-year-old male will be as low as $117 up to $527. Again, that's a month. That's for a 65-year-old male. By the time he gets to be 90, we're looking between $205 and $511 a month. Now, what's the difference between cheap and expensive? The cheaper plans are harder to qualify for. They're only going to take the most healthy of the people. They don't want to insure people who have illnesses or diseases, so they're going to control their cost. The more expensive ones, they take everybody. And we can expect at some point our premiums are going to go up across the board under Medicare supplements. So in Illinois, again, we're going to range from, if we're lucky, about $105 right when we turn Medicare, all the way up to $568 for that same coverage when we get older. All right, in the great state of Missouri, we can look at the rates here. So for a 65-year-old female, the premium's as low as $157 a month, going all the way up to $338. By the time she hits 90, we can expect the premiums to be from $249 up to $682 a month. For a male, again, a 65-year-old non-tobacco using male, it's as cheap as $174 a month up to $351 a month. And by the time we get to that 90-year-old benchmark, Male will be between $275 and $767 a month for that Medicare supplement. This is assuming that the rates stay where they're at right now, but as claims go up, the premiums also go up. So again, this is according to Medicare.gov of the current plans right now. All right, and in the great state of Iowa, take a look at the numbers. They're cheaper for Medicare supplements in Iowa, which is why Medicare Advantage plans are not as popular in Iowa. But we're looking as low as $92 a month for a 65-year-old female non-tobacco user, up to $438 a month. By the time she gets to 90, that spread will be between $182 and $527 a month. For a 65-year-old male, we're going between $101 up to $495. And then for a 90-year-old male, between $201 and $606 a month. Now, again, just because we start on the cheaper side doesn't mean we stay there. And one of the issues that I have with Medicare supplements is the really cheap ones will shoot up in price much faster than the ones that are a little bit more stable. So just keep that in mind. Just because it's cheap now doesn't mean it's going to be cheap forever. You're going to be somewhere in between that range that we see here. All right, so how is the premiums figured out? Well, it makes a difference on what type of plan that you have. So one of the things we go to is what's called community rating. Now, these are rare. I really don't have them in my area, but a community rating means that everybody's going to pay the same premium, regardless of age. Whether you're 65 or you're 85, it's the same premium. It's based upon the community as a whole, not your personal age. That's a lot like Medicare Advantage plans work. It's fair for all ages, but still subject to inflation and company-wide rate increases. The second option is issue age rated. With this method, your premium is based upon the age when you first buy the plan. So the younger you are when you enroll, the lower your premium is going to be, and it's not going to increase just because you get older. It's great if you buy it early, but the rates are still going to go up over time due to inflation or claims experience. The most common one, though, is the attained age rating. This is the one that confuses people the most. Here, your premium is based upon your current age, and it's going to go up automatically as you get older. It may start cheap, but it could become the most expensive one over time. So remember, the same coverage, different pricing models. That's why it's so important to make sure you talk to someone who understands the system and can help you choose a plan that works for your health and your budget. All right, some big changes in Illinois in 2026. Illinois is going to transition from the mmai model, which is the Medicare Medicaid Alignment Initiative, and they're going to change to the standard dsnp. That stands for Dual Special Needs Plans. So this is a big thing, and it makes a big difference. It can make a big difference for you or someone you love. So right now, many people who have both Medicare and Medicaid in Illinois have a program called mmai. And again, that stands for Medicare Medicaid Alignment Initiative. It's been around for a while, and it helps people combine both benefits of Medicare and Medicaid into one plan. But the big news is the mmai is ending at the end of 2025. Starting January 1st, 2026, Illinois is changing to a new kind of plan called a dsnp, which stands for Dual Special Needs. So there's a big difference. Both mmai and dsnp plans were made for people who have Medicare and Medicaid, but dsnips, dual special need plans, are part of a newer, more modern system that gives you the same extra benefits like dental, vision, transportation, and more, and it lets Medicare and Medicaid work together in a more organized way. It makes it easier to get the help you need when you need it. You don't have to worry about as much. So while the name is changing, your coverage isn't going to go away. In fact, most people will find it's even going to be better with a coordinated care, and it's going to be easier to use. So what do you need to do? You don't have to figure this out alone. This is why we are here, to answer your questions, to help guide you, help you compare your plans, and make sure you get what is right for you. And as we get closer to 2026, we're going to help guide you and everybody else through this process step by step. All right, so the mmai did not exactly fail, but it didn't work the way that they wanted either. It faced a lot of challenges. That its limited success led to a planned sunset at the end of 2025. And here's why it's being phased out. So, number one, we have complicated administration. Imagine that. The government gets involved with this and things get complicated. So it required a three-way contract between CMS, that's federal Medicare, the Illinois Department of Healthcare and Human Services, that's Medicaid, and the health plan. So they managed the structure created by a lot of bureaucratic hurdles, delays, inefficiency, and extra expenses, and it was just a mess. In many cases, the mmai plans did not have the same network as the regular plans with Medicaid, so we led to network disruptions. There's also, number two, a low initial enrollment and a lot of confusion. When this first launched, the enrollment was voluntary and passive. That means people were automatically enrolled. They were given an option to opt out, but if they didn't pay attention to that, all of a sudden they found themselves on a new plan and didn't understand why. Many dual eligibles were confused with the new system or unaware even that they were enrolled into it. Most, my clients anyway, opted out because the benefits they didn't match up with what they could do outside of it. Overall, the mmai plan that Illinois had did not work for most of my clients' needs. So there's also poor communication and outreach. Community education and plan communication were very inconsistent. Most people didn't know who to call, where to go for help. Advocacy groups reported beneficiary frustrations with customer service and access to care. The number one reason for this is an agent, like yours truly, could not sell the mmai plan. So when my clients were moved from the plan I had them on to the mmai plan, they lost our support. So they had to figure everything out themselves. That led to some major issues. There's also inconsistencies in care coordination. One of the mmai goals was to improve care coordination between Medicare and Medicaid services, but in reality, the integration varied between plans and regions. Some plans struggled with coordinating long-term services, behavioral health, and social supports. And there's mixed results when it came to cost savings and quality. While the mmai aimed to reduce the cost through better care and coordination, the evidence of savings was limited or not existent. Some quality measures improved slightly, but overall the results could not justify continuing the model under its current structure. So, CMS, Centers of Medicare and Medicaid Services, decided to end the Financial Alignment Initiative demonstrated nationwide by 2025. This means mmai is going away. The focus is shifting to FIDESNP. That stands for Fully Integrated Dual Eligible Special Needs Plans. It's a special type of DSNP. These can be streamlined care without the need for three-way contracts. These plans offer more flexibility, federal-state alignment, while retaining integration goals. So the bottom line is, while the mmai didn't fail outright, it did fall short of expectations in a lot of key areas like integration, enrollments, and administration, the important ones. The upcoming DSNP transition in 2026 aims to preserve the original vision, better care for dual eligibles, in a more flexible and a more scalable model. All right, so in a nutshell, why is it ending? It was complex. People didn't understand it. People didn't know what they had. There's a lot of confusion. People didn't pick it. It was picked for them. Very poor communication and outreach, very inconsistent as far as care coordination. The results did not justify what they're going through. And again, CMS, the Centers of Medicare and Medicaid Services, are the ones who decided that we're going to end this nightmare and just go to the standard dual special needs plan. All right. Dual special needs plans have been around in Missouri and Iowa for a long time, and they are extremely popular. The dual part of dual special needs means you must have Medicare and Medicaid. Now, there are different levels of Medicaid that you can qualify for some plans, but typically you have to be a full Medicaid beneficiary to get the dsnp plans. So with the integrated coverage, there's fewer gaps in coverage, simplified access, one insurance card taking care of everything. It makes things much, much easier. And just like other Medicare Advantage plans, you get a lot of extra benefits that Medicare and Medicaid don't always offer, like dental, vision, hearing aids, over-the-counter allowances, transportation benefits, even gym memberships or wellness programs. And like again, most Medicare Advantage plans, there's zero or low cost sharing, where Medicaid will pick up your co-payments out of pocket. Most dsnp members don't have to pay any premium or pay anything when they go to the doctor or the hospital. But it gets better than that. As they say in the commercials, there's more. You also get what's called care coordination support. Most of the plans are going to assign a care coordinator or case manager to help them make sure they get all the things they need to have, whether it's scheduling appointments, managing the prescriptions, understanding the valuable benefits that they have, and coordinating care against multiple doctors and multiple specialists. It's also simple and peace of mind. By combining Medicare and Medicaid into one plan, there's much less confusion. It's much easier to navigate complex systems. And again, there's one point of contact. You talk to your dsnp plan. You don't have to talk to Medicaid or the state or this or the other. It's just one stop shop. And with the government encouragement, federal and state governments are pushing towards a better integration of services for dual special needs. And again, that's going to be the FIDESNP as a key part of that strategy. But there's even more than that, just like the commercials on TV. This is what you see when you see the ads on TV. You get the flyer in the mail, say, hey, Rick, I heard we can get groceries, we get utility benefits, we get money back on our Social Security check. These are the dsnp plans that will do that. So some of these plans will literally have monthly allowances in the hundreds of dollars for groceries you can use at Walmart or Kroger's. You can use for over-the-counter items. Most of the plans will have home delivered meals after you get discharged from the hospital. Some plans will actually have utility bill assistance. They're going to help make your electricity, your water, your gas, your internet, your phone bills, cell phone or landlines. They're going to help pay those utility bills for you. Now, the important thing, and this is the critical part, this is not the same everywhere. So the plans are going to vary by company and by zip code. Not every dsnp plan has all these benefits, but it's going to be advertised. Like everybody can get that when we get to the annual enrollment time. There's going to be so much noise and confusion. It is going to be crazy. That's why I want to start talking about this now. The amount that you get for utilities or food is going to range. Some of them as little as $50 a month, some over $270 a month. Now, these are the ones now in Iowa and in Missouri. So in Illinois, I don't know what it's going to look like. We're not going to know until October, but the plans can be very rich and it's very worth anybody's time who has Medicare and Medicaid to look at these dual special needs plans. By definition, most people who have Medicaid are living on $1,200 a month or less. That is their entire income. And if they can get $270 for healthy groceries, that is a huge thing for that demographic. That they can actually afford some milk and some meat and some fresh produce, where before they could only do processed foods or get whatever they could get at the food bank. It is just a huge, huge benefit that I'm excited for people in Illinois that we finally get one of these plans. All right. So, with great power comes great responsibility. Starting in October, probably even before that, the telemarketers are going to be relentless. There's going to be a target on Illinois, especially anybody that might be middle to low income. That it is going to be horrible. It's already bad. You can expect mass communication that's going to go out. Every agent's going to try to get your business and switch you over to a plan, whether or not your doctors or medicines are covered. It's going to get bad. It's going to get really, really bad. So what I need your help with is to start the communication now, to do education now, especially if you're in Illinois and you have Medicaid or you know people who have Medicaid in Illinois. We are going to start creating a list. And as soon as we can start talking to people, we're going to have appointments set up as soon as October 1 gets here to make sure that they get the most up-to-date information and get support after they make their decision. So remember, Medicare or the state of Illinois is never going to call anybody. They do not call you. If someone is calling you, try to talk about your Medicare options, it is a scam. They are illegal agents who are trying to switch your plans, and they're not going to be there to take care of you. They're going to confuse you with fake or misleading information, and sometimes it's a flat out fraud. So be advised. I'm going to have a lot more information about this coming up, but this open enrollment time for anybody who lives in Illinois, be very, very careful who you give your Medicare number to. We can expect some mass disruption coming up. All right. Some of these people who work in what I do, they'll sell ice to an Eskimo. They will tell anybody anything to do whatever they need to do to close the deal, to get that check mark, to get that commission check. They're not going to be there to support you after the sale, at least not most of them, especially if they're cold calling you. So you could choose who you want to do business with. You can choose whether you use a broker like Thomas Family Insurance that's going to be there after enrollment, or you could spin the wheel and hope you get the right plan, because whatever you do, you're going to navigate that on your own. So I encourage you to stay away from the people selling ice to Eskimos. Deal with a professional in your area that's willing to sit down and talk with you face to face, not just to sign you up, but when things get complicated down the road. All right. So as of right now, what I have been told is there are 4 carriers that have been awarded the contract for the dual special needs in Illinois. Those carriers are Aetna, Humana, Meridian, which is a WellCare company. It was from Centene, the company who owns WellCare, and Molina. Now, if you're paying attention, for those people in the Quincy area, none of these are in network for Blessing Hospital. That is an issue. I have a meeting with Blessing Hospital late April, and I am bringing all my guns ablazing. I'm saying, you got to get back in the network for Aetna. It's going to be horrible for you and for the clients if this doesn't get fixed by January. So I'm hoping to get Blessing Hospital back to the table to talk to Aetna and Humana and some of the other ones to make sure that you can go where you need to go and get the benefits that you need to have. But as of right now, people in Quincy, pretty much Molina will be the only dsnp plan that will be able to offer and be able to go to Blessing Hospital, if they keep the same kind of setup that we have with other states. Because if the DSNP is an HMO, it doesn't matter you have Medicaid, you must be inside the network. If they put it under PPO, there's a lot more flexibility. All that information will be coming out in October. That's going to make a huge difference as far as what I'm going to recommend. If you can keep Aetna and get $300 for food a month or whatever it's going to be, and go to Blessing Hospital and be able to go to Great River in Iowa or wherever you're going to go, then that could be a good option. But it doesn't matter all the benefits that you get, all the perks, if you can't go where you need to go. So just keep in mind, as of right now, the 4 carriers that Illinois will have for the dual special needs are Aetna, Humana, Meridian, and Molina. All right. So if you or you know someone in Illinois who has Illinois Medicaid, we want to get a scope of appointment on file for you. Those are good for 12 months. So the ones we did last year will be expired. We're going to need permission to contact. So if you're already one of our clients, I have permission to call you and we're going to reach out to you. But your friends, your family, your neighbors, other people who might need this information, I will not call them without their permission first. They can call me, or we can get a permission to contact form filled out ahead of time, and then during open enrollment time, we can start talking about that. And I am going to start scheduling appointments in October as soon as possible for the people who have Illinois Medicare and Medicaid. Now, October 1 through October 14th, we can talk about everything, but we can't actually sign up until after October 15th. But most of these presentations are very quick because Medicaid picks up your out of pocket expenses anyway. So we just need to verify doctors, verify medicines, and look at all the extras to find out what's important to you. One plan might be really, really, really good at dental. One plan might give you a lot of money for groceries. Another one might help with utility bills. We want to pick the plan that's going to be the best for you. That is our job, to navigate that Medicare maze and provide you that guidance. So please, there's going to be more information coming. But if you know anybody on Illinois Medicaid, we want them to contact us soon so they can get on our list, so they are the first people talking about this when it's eligible, starting October 1. The confusion is going to be astronomical this year. I am telling you, your mailboxes will never be fuller than what they're going to be this year. Everybody is going to be sending out flyers, and the deceit is going to be imminent. People are going to trick people into thinking that they're Medicaid, that they're Medicare, that Social Security. They're going to pull every trick in the book to try to get to change your plans. You can work with them, or you can work with us at Thomas Family Insurance, because we're going to be here to help, not just to sign you up for that plan, but years and years and years down the road. All right, this went a little bit longer than most, but this one is important, especially if you know anybody on Illinois Medicaid. Share my information with them. Call Trish at the office. Her number is 217-771-1722. That's 217-771-1722. And she can get a permission to contact form. She can get a scope of appointment, and we'll get you on our calendar starting October to talk to you about these new plans. Now, I can't officially give you any information about 2026 plans until October 1. But I'm going to be well prepared. Starting in September, I'm going to know these plans inside and out to make sure when the time comes that we at Thomas Family Insurance are going to take good care of you. But I need your help to share our names with other people. There are so many people who are going to need help, and we are here to help as many of them as we can. It helps our business grow. It helps us maintain retention, helps us keep our clients, and most importantly, it helps this whole process, because when you have a good agent, it makes your experience much better than when you try to do this alone. That's what we're here for. All right, thank you very much. You guys have a wonderful week. If you need anything, as always, reach out to us. Thank you, and God bless.